What's up, everybody? Thanks again for tuning in to the Owens Recovery Science Podcast. This is Kyle Kimbrell. I'm going to play host today for you because I've got Johnny Owens on here as a guest for the second time now. He's been a guest on his own podcast. That's a thing. If you didn't know, now you know. We've also got Larry Cahalan on here, and we are going to discuss their contributions to the PACER project. If you don't know what the PACER project is, it stands for Post-Acute COVID Exercise Rehabilitation Project. It was organized by the Cardiovascular and Pulmonary section of the APTA, as well as the Acute Care section of the APTA. And what those two groups have done is assemble some clinician experts to provide some learning opportunities for you for free. All you have to do is go over to the YouTube channel for the Cardiovascular and Pulmonary section, or you can go to the APTA Learning Center and you can watch these videos, answer some questions, and get free CEUs. We'll have links to both of those in our show notes. These videos address how one might perform rehab after someone has had COVID. So tackling a number of different angles regarding persons following infection with this coronavirus and the disease process that follows that. So we hope you enjoy Larry and Johnny's contributions to that, but we also hope you'll take the time to watch all of those videos because it's just a really great resource and it's free. I mean, who doesn't love free CEUs? Especially right now when we're all sitting at home and not necessarily having as much fun getting out to these courses. But speaking of courses, we will be getting up and going very soon. We've got open courses scheduled for the middle of July, beginning in Kansas City, Kansas, and Dallas, Texas on July 18th. You can find us. Then in Santa Barbara on July 25th, Falls Church, Virginia, and Memphis, Tennessee on August 1st, Miami, Florida, August 8th, Golden, Colorado, August 15th, and then finishing up August, we're in Austin, Texas, the home of just about the best barbecue you'll ever taste in your entire life. Sorry, Kansas City people, but it's just the way it is. So we hope to catch you at our courses soon if you haven't already been to those. Hope you enjoy this podcast, and let's get this thing going.
This is the Owens Recovery Science Podcast, hosted by physical therapist Johnny Owens.
All right, and welcome back to another installment in the Owens Recovery Science Podcast. This is Kyle Kimbrell, and I've got two very special guests, one who is no stranger to you and Johnny Owens, and Mr. Larry Cahalan from University of Miami. Larry, when I say Miami, I have to slow everything down because every time I reference y'all's work in our courses, I end up saying Miami. I'm going too fast, and I don't know what happens. This weird alliteration thing goes down in my head. So from University of Miami, Larry Cahalan. Larry and Johnny both did PACER projects that are out now. Johnny's came out last week. We got that bad boy out there. And Larry, yours came out, 2-3 weeks ago, I think?
Yeah.
Is that right?
Yes.
So Larry's is on inspiratory and expiratory muscle training. We want to talk a little bit about that today and how that might really begin impacting many of our listeners and certainly just various different rehab professionals kind of the world over and in all kind of different settings. And then we also want to talk a bit about Johnny's PACER project and how those two worlds meet. We just had a fun convo discussing all this sort of off air. So we'll just try to repeat all that on air because it was really good just kind of hearing these guys' bright minds and where these wormholes that they've gone down during our COVID lockdown. Larry, why don't you we've had you on before, but maybe just tell us a little bit about where you are, what you do, that kind of fun stuff.
Sure. I'm here at the University of Miami, and I've been here, just about 10 years. Moved here from Boston, where I lived for about 25 years, and have been very, very happy here in Miami working with my colleagues. And it's exactly how I met Johnny as well. He came here years ago when he was just a young boy and gave us instructions on how to do BFR. And I went to sort of just, ask this guy questions and, figure out, is there really something to this? And by the time we finished, we actually had lunch at a local brew pub, and we probably went back there for dinner and probably didn't leave until midnight. We were not drinking. We were just actually talking about research and
Okay,
research
look,
projects.
let's be truthful, at least on the podcast, Larry.
Sorry.
It's all good. That's too funny.
But to make a long story short, it's a little bit of the care, the practice I do is looking at people with breathing problems, oftentimes individuals with heart and lung disease. But we've been looking at athletes as well and trying to see if there is a way that we can improve performance in those individuals who have disease and in those individuals who actually are athletes, and just trying to excel in their performance by improving their inspiratory, expiratory work, endurance, power, strength, whatever it is we're trying to achieve.
That's cool. And so, like in my head, and put me in my place, Larry, but this is kind of where I go. I'm just like, okay, we'll just work a little bit harder. You'll start breathing more, and that'll do it. Why wouldn't that work?
It will
why
work.
am I wrong?
No, it will work to some degree, but I think, just like with BFR, and I think I'm really happy that before we did start this podcast, you asked, are there some similarities between BFR and with inspiratory or expiratory muscle training? I think there definitely are, and I'll try to talk about some of those. But I think the question that you asked in regards to just breathing heavy and trying to improve respiratory performance, you need a workload. You need a resistance that muscle, the muscle group, whether it's the inspiratory, expiratory muscles or both, that they need to work against. And by providing a more optimal workload, you're going to hopefully strengthen and maybe improve the endurance and power of those particular muscles, and allow the person to hopefully ventilate a little bit better. And maybe that will slow their respiratory rate down if they started, for the most part, like a person with COVID-19 with a rapid respiratory rate, and allow them to have a more comfortable breathing that would hopefully allow them for better oxygenation, removal of carbon dioxide, and just better metabolic activity overall.
Cool. Very, very cool. So I know one of the things you touched on in your talk was you went through a few different devices that look like that people might use. And I know you've done a decent amount of work in that space. So I wonder, we had kind of had that talk about, trying to make this practical, and, so many of our listeners hear inspiratory, expiratory muscles and their eyes kind of glaze over, much like when we get kind of talking into the weeds on BFR sometimes. But, I guess my question would be, okay, well, I think of muscle, regardless, whether it's cardiac muscle, endothelial muscle, the diaphragm. We know muscle needs some kind of a stress to adapt. It has to be provided with that. And if it doesn't, and that's a two-way street, right? Because if we remove stress, there's an adaptation that occurs as well. And so how would you go about determining, say, the right load to use with some inspiratory muscle training?
Yeah, no, great question. You would use a manometer, and that manometer would hopefully provide you with a maximal inspiratory or expiratory pressure. Some of these manometers are expensive, about $1,000. So back in the day, my colleagues and I just took a regular blood pressure cuff, the sphygmomanometer from a blood pressure cuff, removed the rubber tubing, and then put some oxygen tubing onto that particular the manometer, the sphygmomanometer, and then attach that particular oxygen tubing to a mouthpiece. That allows the person to use the sphygmomanometer as a manometer to measure inspiratory and or expiratory pressures. So you can get a maximal pressure. You then can train the person at a percentage of that maximal pressure, and you can even use that sphygmomanometer as a training device. And there really have been a good number of studies, both in healthy individuals and individuals with disease, where if we improve, like you said, the strength, the endurance, the power of the respiratory muscles, performance does seem to improve, especially in less elite athletes. The more elite, you're not going to get the same adaptations, very likely because they are at that elite level. But I think overall, if you were to use a sphygmomanometer, you could test and train, but there are lots of other devices that are available that are on the market. And in the PACER presentation, I did try to make it practical because it is expensive to buy some of these testing devices, but you don't need them. They're nice to have. But the other thing with COVID-19 is, the whole virus and the contamination of one piece of equipment being used by another person. So
Yeah.
one thing I tried to stress was the importance of maybe single patient use. And you could buy a sphygmomanometer, blood pressure cuff pretty cheaply at a CVS or Walgreens. And then I tried to outline how you could just take a simple piece of tubing and attach it to a mouthpiece and do some of those same measurements and or training methods.
Yeah. I like the term less elite athlete, I think is what you said. I feel like,
Yeah, I didn't want to, yeah.
I feel like I fall into that category for sure. So I'm kind of curious too, just in thinking, just relating back to skeletal muscle, because it's where my head goes. I'm supposing that there are certain times where doing like a maximal exertion might not be indicated. You might need some sort of a surrogate. Is that because like, for example, in orthopedics, we'll use like a 10 rep max versus a 1 rep max, because maybe we have some surgical precaution, or there might be some fear on the part of the patient, that kind of thing. Maybe you have a lack of equipment. Is there a surrogate that you could use to kind of run an end around if you had to?
In terms of obtaining a maximal or maximal
Yeah. In
pressure?
terms of, yeah.
I think it's a great question. Yeah, I think if you're really going to hopefully stress the person in terms of their respiratory muscles, and keep in mind the respiratory muscles are skeletal muscles too. They adapt differently to training in some respects and to disuse. And I'll talk about that just briefly. And if you can, just remind me, because I think it's an important concept to think about for
Yeah,
COVID
absolutely.
patients also.
Yep.
But I think one thing that you can do with some of the testing and training devices, or training devices for the most part, is you can actually dial in a certain amount of resistance that's identified on the device itself or in a table, where we know that if a person, because of their age and gender and their health or not, we can identify that their strength is probably about 50 centimeters of water. And therefore, we might want to train them then at half of that, 25 centimeters of water, and we can dial that in on the device without actually even measuring the maximal pressure. Because, like you said, there may be a condition, maybe a person had a sternotomy, and we don't want them to do a maximal inspiratory effort or expiratory effort. And at that point in time, we may just try to give them a low load. And we know that, let's say their maximal pressure maybe before the surgery was this, and now we can train them at a lower percentage of that and not have the pain or the other problems that could occur with excessive inspiratory efforts.
Very cool.
Yeah, that's cool. Is there a situation where you might, like, if let's suppose we have someone post sternotomy or some sort of something like that ends up in like an outpatient clinic, and they just walk in, and the therapist is like, man, I'm typically total knee boy, and now I've got this person. How might you kind of suggest that person goes about doing some sort of a baseline assessment and determining those things for them, if they're not given anything from their hopefully their physical therapy clinicians that they're working with in the hospital? Is there some advice you would have there?
Yeah, great question. I think a couple things you could do very simply before you try to implement any kind of training or testing would be to, find out how far or how long it's been, how far from the surgery has it been, and, were there any complications? And then just identifying and looking at the actual incision, just like you might with a person who had an ACL repair or whatever else. If the incision looks good, while you're looking at the incision, hopefully the person has their shirt off, or some degree, you can assess their breathing. Are they actually demonstrating a descent of the diaphragm? Do they have a little bit of movement, lateral costal area? Are they using mostly the upper chest? And if you identify some of these problems, you might actually be able to facilitate just better breathing. A lot of patients, they still may have a little bit of pain. They might breathe with a greater respiratory rate because they can't get the full volume of air in. So just by trying to get them to slow down or maybe focus on learning how to breathe again, I think you can just do that. And then if the person is healthy and you have a manometer sitting around, you could do a measurement based upon how long it has been. And we had a discussion yesterday actually with a group of DPT students doing some research, trying to identify if you're going to do any kind of testing after a sternotomy or any kind of surgical incision on the thorax, how long would you wait? And we came to a consensus of maybe 4 to 6 weeks based upon the physician who may have been, in there and knew what was going on, or to just get a feel for the patient and their symptoms as well.
That's great. I feel like we've made Johnny sit there quiet for
I know.
long enough. Now we've just been kind of shutting him out of the conversation.
We should include him.
It is his podcast after all,
Yeah.
So
I'm taking this all in, man. This is
he's just digesting. And there's quite a few things I want to come back to, Larry. But Johnny, you did the blood flow restriction podcast, or excuse me, PACER project, which was cool. And I was, of course, around for all that, so I know what went down and how challenging it was for both you and Larry to just talk into a computer with either only me or no one on the other end of that. But you've been working on this really, since the end of March. You've been
too long, man,
to figure out where to go with this, because it's and I think we should kind of, I don't know, say a disclaimer, but is say, it's a lot of theory, and it's a lot of kind of taking what we feel like we've got an idea about, and in some cases know about BFR and exercise, and trying to kind of translate that to what our colleagues might be seeing in clinic coming up, and where things might kind of go in the future. So you want to just maybe kind of take us down the road of where you started and kind of how you ended up where you ended up?
So when I get into these wormholes on something like this, it's like a deep, dark place. And my wife was like, will you just get this thing done? Because I just bury myself in way too many papers, and I can't stop thinking about it. And you guys know, I was probably halfway around Kyle and our team at ORS, on these calls. I'm just like, all right, let's get this over with. I got to get back to working on PACER, and I'm thinking about PACER, and I got to call someone today and talk to them about PACER. Larry and I are like calling some guys over in Zurich to see if we can get initial data from them and stuff like that. But here's what I think was really interesting, and what's timely on it is, we've really made this shift over the last few years of, okay, blood flow restriction, we see the application in the orthopedic world and the application for muscle. And then we're like, okay, there's also this application for bone, and then there's this application for tendon. But I've really been deep into this population that we're talking about here with PACER. And things just kind of timely were coming out perfectly, I think, to help with this talk. And also, we got work going on with Brian Irving at LSU, looking at mitochondrial respiration, and I've talked a lot with him, and he's helped me understand like what hypoxia would do for that. The Germans and the German Diabetes Center, we're looking at how BFR can maybe lower insulin levels, and went down a kind of deep dive with that. And Dr. Pesta's lab, Alex Franz over in Germany, is doing his peripheral arterial disease work that we're working with. Jamie Burr's got his reactive oxygen species stuff, and then real timely. Kyle Hackney's group put out their paper on ACE2 last year at conference, and we've had it and been waiting for him to get it out in his group. And that came out and really fit perfectly into this whole oxidative stress, which I think we can go into later. And then Dr. Annie Bain's Parkinson's paper came out looking at the endothelium. So having kind of all of that in my mind, and we've been working on it and seeing now where this application could go. I think that's why I really wanted to get it right. I didn't want to do it too quick, because as soon as I was going down, like, it's all respiratory, let's look at the lungs, this is a problem with the lungs, and it's going to be COPD and all of that. It wasn't anymore. It changed to, it was a problem with the endothelium, it really looks like. And the people who took the biggest hit, and another paper just came out, a really, really large one, looked at it, were the oxidative stressed out individuals, the diabetics, the cardiovascular disease folks, the obese patients. And so I think us waiting and learning more and more about this, it started to fit even better into where we have been going over the last couple of years with blood flow restriction. So that's the wormhole, and I think we can go deeper into it. A lot of drinking. That drinking Larry said we did do in Miami, I've been doing it over the last few months. Getting angry, yelling at the computer.
Even Kyle developing your beer load.
Yeah. And I guess in case people don't know, it's not like PACER is this YouTube sensation or anything, but what PACER, my kids
It's
aren't
not? I
watching
thought it was.
No,
Your
it's
kids
not.
are.
They're not, if we could work it into
I'm surprised.
Roblox, yeah, if we get into Roblox, my daughters would be all about it. I got my PACER monkey yesterday for my Roblox. But PACER is, what is it? The post-acute COVID exercise rehab project. And basically, Larry's, the section he's involved in, the cardiovascular and pulmonary section, part of the American Physical Therapy Association, said, let's get kind of experts together and put at least some stuff out there for the community to digest that typically maybe don't see these post-intensive care syndrome patients or intensive care patients at all. And also, what can we as a rehab community start to understand about COVID and physical therapy? And so it's just a ton of YouTube videos. You can get CME credit for it if you go to the APTA Learning Center and if you're an APTA member. And so I think it's one of those things that, hopefully it's kind of like evergreen. COVID's not going away. And even if this does go away, these post-intensive care syndrome patients and the oxidative stress patients, they are not going away. And those are the ones that, man, I think if you just listen to mine and Larry's talk. But I mean, I'm just saying, that's where I think it can be really valuable to make us rethink how we're going at those types of individuals. There's a lot more of them than there are ACLs, big time.
Yeah.
And they could really probably use our help a lot more than hey, I could get this guy to squat on a freaking Swiss ball touching his nose or whatever, so. But we won't go down that road.
Phenomenon.
Yeah. So I will say I broke my talk into two parts, or mine and Larry and I did it together. I did all the talking, which is maybe good or bad. So, but the way we broke it down was to look at how blood flow restriction could work for the post-intensive care syndrome patient. And there's a lot of those. And so we all think of the ICU COVID patients because that's all in our face right now. But there's greater than 4 million post-intensive care syndrome patients a year. And those are people who come out of intensive care and they have severe disability. And that severe disability is physical impairments, which is what we're supposed to address. Strength, they have pain, they have decreased quality of life and decreased ADLs. And there's a big systematic review meta-analysis that basically, it kind of said rehab doesn't look like it's doing that great with these people. I wrote it down. Rehab following ICU discharge makes little to no difference in quality of life or mortality in these post-ventilatory PICS patients. That's like an ouch when you have a giant systematic review meta-analysis says, yeah, what you guys doing doesn't really matter or help. And so for the PICS patient, I think it's pretty obvious. They get out, they're so disabled, they can hardly do anything. So just getting them to walk or do sit to stands is, you got limited time. You just got to do what you can do to make them safe and get home and hope that they can do okay. And it's I don't want to slam therapists here with it, but you just can only do what you can work with. But as we know with blood flow restriction, well, then let's do those low-level exercise with the tourniquet. And
let's put them on a bike. Let's add some neuromuscular stimulants.
Yeah, put them on a bike. Have them walk.
Do these things that we know can cause change.
Yeah, in the SNF unit, in the acute care setting. And so then I think we're going to get a real effect from what we're able to do with them. And so I really want to task our association, our community, that let's really look at something like this, because there was this big PICS paper that came out in the PT Journal a month or so ago. And it was like, okay, when these patients get out, they need to do 70% of 1 RM ACSM guideline lifting, and they need to do high intensity interval training. It's like, give me a break. That sounds great. We should say that, but there ain't no way in hell it's not going to happen. Even if the patients wanted to try and do it, I think most therapists would be scared out of their mind, and they should be. Those patients are not ready for that capacity. So this was a workaround.
Yeah.
Very good point.
The second piece then is where I got really, because that's easy. If you're to ask me, like, how would you do this in an acute setting with someone that was, deconditioned? I could talk to you all day about that. And I think anyone that listens to us or follows us is like, okay, this is like a no-brainer. Give me a tourniquet and I'll show you what we can do. But then it was like, what about this COVID thing? is there anything with putting someone into hypoxia? We use high levels of hypoxia the way we do it. Is that making things better or making things worse? And so, again, Kyle, like I said, some of this was leaks. Some of this, I think, actually has some good theory behind it and actually has some papers behind it. But if you let me talk about the pathophysiology real quick, there's the ACE2 receptor is what the virus attacks. And so the ACE2 receptor fits perfectly into COVID-19, and COVID-19, it starts as a disease of the lungs. And so the virus comes in, it goes in the lower lung fields, and it attaches to the ACE2 receptor. And then once it's there, it basically replicates itself within the cell through that ACE2. It destroys the ACE2, basically hijacks it and crushes it, and then it allows more viral load to come out from the cell, and they go out searching for more ACE2, and then they also look to be expelled out of your body to go someone else. The problem was, when you started looking at all the people that were dying from this and getting hospitalized, the numbers in New York especially, and now we're getting them from all the other countries, for COPD and asthma and ARDS and things like that, those folks, they were really getting hospitalized and dying at not much different rates than they normally do. But then we were seeing, man, these obese people, the diabetics, the cardiovascular disease, they were the ones that were getting hospitalized, and they were the ones that were dying at a super high rate. And then we started seeing these people all have blood clots. They're opening the lung field, and they're like, instead of just seeing like frank pneumonia, they're seeing blood clots everywhere. And people are getting strokes. And the poor actor, the Broadway actor who had to have his leg amputated because he was clotting out in his leg. When you start seeing blood clots, then it's an endothelial problem. It's not a lung problem anymore. This is a disease of the endothelium, because when the endothelium of the artery gets damaged, the artery wants to repair itself. And that's where you see that ACE2 gets hijacked on the endothelium, because the endothelium of the arteries is lined with ACE2 receptors. And so when it gets damaged by COVID, then von Willebrand factor comes out, factor VIII comes out, and you start to get clotting that happens. And so now we are all of a sudden into an endothelial problem. And so why were the cardiovascular disease, the diabetes people, the obese people, the ones that were having a higher mortality and being hospitalized? Because they already have oxidative stress. They don't have as much ACE2 receptor to help fight this problem. And so then you go back to this, what does ACE2 do? ACE2 basically decreases oxidative stress. It takes down free radical production. And so we needed to start looking at, does BFR, does exercise in general increase oxidative stress? Because if these oxidative stressed out people are dying from this, then we need to look as rehab professionals at interventions that have less oxidative stress. And so that was kind of the second part of mine and Dr. Kalen's talk.
And you made a nice little picture. I'm a simple guy. I like pictures. We had a talk with some pediatric therapists yesterday that are doing some ACL work, and they had a very funny OmniRes picture that you'll have to listen to that podcast to hear our conversation around that. But pictures are great. And Larry, you referenced a picture, it was more of an animation, I think, in was it Dr. Tretter's presentation? Is it Tretter's?
Oh,
Steve Tepper.
Tepper. There you go. He had a nice, he kind of described this animation as sort of what happens with gas exchange and that sort of thing. And then you had some additional kind of thoughts off of that. So you want to maybe describe that for our listeners, because they may not. That was the very first
one.
PACER project release, I believe, was Steve Tepper's. Kind of went into the pathophysiology of it.
Yes, Steve's a good guy, and he's a smart guy, and did a very nice job using the Wasserman and Whip gear schema that presents essentially the way that oxygen may travel through the lungs, then through the circulation to the muscle, and then there's at the end of that particular diagram how the mitochondria respond to that, and then the removal of carbon dioxide through the same series of gears. And underneath that particular gear schema, in one of the renditions of this particular figure, they provide a listing of where disorders or diseases can occur. And unfortunately, that interface, as well as underneath each of those gears, you see many of the things that Johnny just talked about as disorders and diseases that unfortunately make that person with COVID-19 that much more susceptible and much more unable now to deal with proper mitochondrial activity, and therefore impairing the person in many ways that Johnny's already, talked about. In addition, I think, an important thing that Johnny did present is that endothelial expression and how BFR does seem to improve it. And there was a nice paper out of Brazil that looked at ACE2 deficient individuals and the way that that affected their heart, the way that it affected their function and their performance. And what they found essentially was that the hearts pumped poorly if they had a decrease in the ACE2 expression. And they also found that activity levels were markedly less than those who were not deficient of ACE2. So I think, it's an important thing. And I've just been really amazed at the literature and the way by which I think that particular effect really seems to be facilitated with BFR in a way that I think really could favorably help the person, maybe even in the intensive care unit, and certainly for the person who's post-COVID from the intensive care unit, where they need to gain the strength, the hypertrophy of the skeletal muscle, but also the improvements that are I think, going to occur within the endothelium and then subsequently muscle.
Yeah, and you both of you kind of touched on the disuse sort of aspect that's going to go along with the patient, and I think something that we maybe forget. I think we on our podcast have hammered it over and over again, and in all the courses that we teach and the blogs that we write, that this disuse state is it's still load. It's just a lack of load, and the body adapts to that. Skeletal muscle responds to that. And you had kind of talked, Larry, it's not just skeletal muscle, it's endothelium. There are other structures that are responding. It's the heart muscle. So maybe you want to talk a bit about the disuse response to these tissues as well.
Yeah, no, it's a great question. Thank you for reminding me. The point I wanted to make earlier is that certainly if the respiratory muscles are not used and or disease bears its ugly head, you will find a change in the muscle fiber type. And in individuals with COPD and individuals with heart failure, and I suspect COVID-19, there's likely going to be a greater expression of type 1 muscle fibers and fewer type 2. And we see this certainly in heart failure and COPD. And what that means essentially is that the person with COPD or heart failure, when they need to take a good, strong, powerful inspiration or expiration, they can't do it because they don't have the generating capacity. They've lost those muscle fibers. So they have an adaptation that occurs just to keep them alive, moving their muscle fiber type to a more aerobic type 1. But they then lack the power. So I think for that patient population, there might be a need to really strengthen them, to get them stronger, to improve their power, to improve their ability to take that full deep breath and remove secretions if they're there. Otherwise, they may have to be intubated and maybe put back into an intensive care unit. And it's different from what we see in the peripheral muscles, as you guys know. When a person is atrophied peripherally compared to the respiratory muscles, we typically find that they actually move from more of a type 1 to type 2. And they lose that aerobic capacity, yet that type 2 muscle is not doing what it should do. It doesn't have the capacity, doesn't have the actual size, the circumference of that particular, the CSA, the surface area is less, and the person cannot generate the pressure that we need to do that powerful activity. And therefore we need to do something like BFR. So.
Yeah, that's a cool point that you made, Larry, because when you were talking about the shift towards type 1, I was like, wow, that's interesting, because like in a spinal cord injury, for example, we see a shift towards like the type 2X, this very hyper anaerobic muscle fiber. And really, I would surmise that the reason is because you've kind of lost some blood flow to the limb. That tissue is just trying to survive. I mean, yep. and essentially, and I always kind of go back to like, look, we're just with exercise, we're trying to tell our bodies it's not good enough, and bodies need some level of stress to respond to. And at some level, it's like it's a life or death kind of situation we're trying to induce at a low level to push these people farther. And that's, of course, our job in rehab is to find that point at which this person can't do this and approach it enough for a long enough and frequent enough that our tissues respond. So, I mean, in that vein, I would maybe kind of go down this road of, all right, the heck does this look like? How, let's say we're in the ICU and I'm a physical therapist, and this would be for you, Larry, as well as Johnny. What do I do? I go in there, I'm thrown into this situation because we have this horrible pandemic that's really kind of affecting all these people. Where does my head need to go in terms of what's happening pathophysiologically? I have to slow it down a little bit. And in terms of just the disease, but then also in terms of our muscle and our heart muscle, our diaphragm, our skeletal muscle, that kind of thing. Why don't we kind of roll down that road of, all right, here's what rehab really looks like. This is our fantasy land based upon what we feel like we kind of know. This is ideal.
Johnny, you want to go first?
Yeah. So I think, and I laid it out at the end of our talk of like, I think this would be progressions. We know disuse happens quickly. Within the first week, in a healthy model, you've already lost probably 3 pounds of muscle of 1 week of bed rest. And we can only imagine in these compromised individuals, and it's hard to get it back. And the longer you're in the ICU, the more muscle you're going to lose. It's pretty obvious. And there's some striking photos of people post ICU of how much they've lost. So it's always easier to slow it down and then get it back than to lose it all and try and get it back. So, again, I'm very used to blood flow restriction. I talk with people all over the world that are doing it and use it in these type of different scenarios. And so for me, getting into an acute care setting, potentially even in an ICU setting, and just doing some sort of passive blood flow restriction, I think, it might be a burden, but some sort of get a tourniquet on, probably a high occlusion, 80 to 100% occlusion, and use some sort of stim to get a muscle contraction on that patient. That we can at least fight off disuse. We've got the healthy models that have shown that. We've got, some clinical models that have shown that BFR in the absence of exercise looks like it can slow the atrophy train. That might be a remote ischemic preconditioning type effect. We're not real sure. But if you add a little bit of stimulus to it, then we might also see that we have less of this free radical production. If you just put a tourniquet on, so if you measure free radical production, and then you put a tourniquet on and you take it up to full occlusion, you see an increase in free radicals. If you exercise at light level, you'll see an increase of free radicals. But if you see exercise at light level with a tourniquet on, we see a decrease in free radicals. And so then in those individuals, again, they're oxidatively stressed, which is just destroying the endothelium. If we're able to get a tourniquet on and do light level exercise, we might be getting some bang for our buck of slowing down atrophy, but also having less of free radical load while we're doing it. So I would think if you could get in at least daily or morning and afternoon for that kind of session in the ICU, that would be the study I would be very interested in seeing. There's already a trial in Brazil that looked at it. A little bit wonky, but still overall pretty decent. And they just did blood flow restriction passively like that and did passive range of motion. And over time, the folks that were in comas that did that had less muscle loss overall compared to the control group. So it's been done. It wouldn't be like, oh my God, no one's ever done this before. It's in a published trial that showed it's beneficial. From that point, then as soon as they're able to start moving, that's when you either get it on and you do low level things like trying to walk or do mat type exercises with it. And then hopefully if they can get out of the hospital and get out to outpatient therapy and do BFR how we would typically do it, some light load type stuff. And the progressions, again, would be in the ICU in the acute setting, frequent, BID or daily. And then once they're out a couple times a week, hopefully if they're able to do that, and then maybe we would get them over the hump.
Yeah.
What do you think, Larry?
Yeah, no, I agree 100% in terms of the BFR and everything that you just discussed. And, from a breathing perspective, if a person's in the intensive care unit on a mechanical ventilator, if they are stable, whether it's COVID-19 or something else, there is a pretty good literature. Well, I should say, if they're stable and they are, let's just say, having difficulty weaning from a mechanical ventilator, or you want to facilitate that, it might be helpful to do inspiratory muscle training. There have not been any studies in patients with COVID-19, but there's a pretty good literature that shows that individuals, if you do some inspiratory muscle training, you're very likely going to improve that, or you might say lessen the atrophy, like Johnny said, and maybe even improve the strength so that the person now can come off the mechanical ventilator and breathe on their own. Because the positive pressure ventilation that the mechanical ventilator provides is not negative pressure breathing, which is how we breathe. It's positive pressure. It's almost like doing CPR, inflating the person's lungs, and it then allows the diaphragm to go into its more shortened, contracted position, but passively. And so that same atrophy occurs pretty quickly after a person's placed on a mechanical ventilator. And so I think, trying to, if the person is stable, especially with COVID-19, trying to elicit a little bit of a decrease, you might say, in the atrophy, and maybe improving the strength and the breathing of a person might be beneficial. And I think, from related studies, it appears also that some of the effects of inspiratory muscle training are not that different from what we have heard Johnny talk about in regards to modulating the autonomic nervous system, improving peripheral blood flow. It also decreases inflammation and oxidative stress. And there also is a training effect upon the heart. And I talked about it a little bit in my presentation. I think these are all important things to think about, whether you're in that intensive care unit or not, and to try to facilitate a little bit greater strength, endurance, power in that person in regards to their breathing, that will hopefully carry over into all the things that we've discussed. And one final point, bringing the two worlds even closer together in regards to hypoxia. Tim Mickleborough in Indiana published a nice paper last year where he actually took a hypoxic condition, put individuals, if I'm not mistaken, into a high altitude chamber and had them do inspiratory muscle training compared to a group that were just inspiratory muscle training on land, not in that chamber. And what he found was that hypoxic condition stimulated more improvements in those individuals than what they found on land, improving the strength, the endurance, the power of their inspiratory muscles. And I think it's an important concept to think about. When I first heard Johnny talk, I thought, how can I do this to the respiratory muscles? I can't put cuff around the neck. That wouldn't be a good thing. So I kept trying to think, and one of the things I think may occur though is there seems to be a systemic effect from BFR, and maybe if you did combine BFR, or if you did BFR after, if you did inspiratory muscle training after BFR or before, I think it could be beneficial and maybe elicit some greater improvement in the respiratory muscles.
There's certainly been a few papers that have kind of given some nods to something happening systemically for sure, but certainly very nuanced as well. If I'm not mistaken, Larry, just kind of sticking with the inspiratory muscle conversation, when people go on ventilators, it's pretty common that they are put on some kind of an inhibitor. I don't know if it's a paralytic or what have you, but something to essentially kind of allow that positive pressure, because we do typically have a negative pressure type situation. So you would end up getting disuse just because of that, I would imagine, right?
Oh, absolutely. And all the muscles, the peripheral, all the muscles for sure. And I think, the example that Johnny talked about with this Brazilian study where they just did passive BFR, really nicely performed study, it seems. And I think it definitely has some relevance to those patients within the intensive care unit.
Yeah, definitely. And I just think it's just so key for us to be, as PTs and even our athletic trainers and various other people that end up working with patients in a rehab capacity, that we really kind of understand that this disuse situation is a problem, and we need to be conversive when we, with regard to it. We need to kind of understand these numbers that we always kind of highlight in our courses, and how quickly this muscle loss happens and how quickly that associated strength loss goes with it. And because if we kind of understand those things and we're intervening in those manners, and we understand how long do you have to do this and how frequently, then we can have conversations and we can start really trying to create what I call Kyle's fantasy land, where we get to manage these people in a way that really causes some change for them. And then maybe, who knows, it's like, well, this research study, it's daily, because we know now you really have to do it that often, that this exercise prescription of twice a week is insufficient. But we definitely don't get there if we don't really understand what's going on. I think on our end, just a lay clinician, I don't think we get there. I don't think we get there if we're not asking for it. If we're just kind of saying we're okay with 2 times a week. Well, I'm actually kind of not okay with it. I think there are people that need it more often. And these athletes get it. Why shouldn't my grandmother get it if she needs it, whether it be outpatient physical therapy or inpatient acute care? I think it's time at some point that we start kind of standing up and going, well, hang on a second, like how come they get it, but we don't, So,
Well, Kyle, and here's what
that's my soapbox a little bit. Sorry.
But I think we've always been going at it the wrong way,
Yeah. Amen. 100%. Yeah. Agreed.
It's been, well, let's restore them back to this level of function. Let's see if we can get them to do this little task, even if it's only at 75% of what they could do before. And the reason why drug companies, they own the planet with this stuff is a lot of times they're like, well, you can do this and it will help slow disease or reverse disease. And so a lot of times when I'm looking for new studies and working with groups, we've been looking at like, can this be something that can heal bone? So then we can say, well, they need to come to therapy because we can actually make their bone heal. And I think that's where we're going with this, with the oxidative stress people. There's this ACE2 is so valuable to reduce free radical production. It basically breaks down the oxidative stress that all these people have. Parkinson's, cardiovascular disease, diabetes, they have oxidative stress, and lots of times that's what's killing them. It's destroying their endothelium, and the cardiovascular disease is getting worse. And so, in my talk, I had is out of the American Journal of Physiology, their heart and cardiovascular section, a paper that was, we need to look at ACE2 treatment-based approaches for vascular disease and cardiac problems. So they're saying the drug companies need to find a way to increase ACE2 somehow to help these people. And that's where something like Kyle Hackney's group, that paper they put out is beautiful. Because it said, after 30 minutes of doing BFR, you saw this really significant rise in ACE2 quickly after one session at 80% limb occlusion pressure. And you saw this big rise in the vascular progenitor stem cell. That now we can start saying, yeah, they need to come to us because we're helping try and reverse their disease. And we have never had that kind of platform to talk about. And now this is such a big thing where we're getting so many people talking about it, these big labs doing it. And Kyle's paper just won June Best of the Best from the American Physiological Society, a best paper to come out. And so that gets attention. And I think we have to start approaching it from that.
Yeah, really, really good points. And I think you actually identified an article that was important for me that was the 4th BFR study in patients with heart disease. And you sent that to me last week, Johnny. And it's nice because it demonstrates what we've talked about in the past, whether it's been at CSMs or just doing chats like this, is that, when you release that cuff, whether it's between sets or let's just say it's after you do that 30, 15, 15, 15, you actually find that increase in blood flow to the periphery now that actually causes nitric oxide levels to increase because of shear stress. And you have massive vasodilation. That is the same thing doctors use to treat heart disease. And so in the study, this most recent study, again, there were no complications in the people with heart disease, and it found improvements in blood pressure over the long term and acutely, and also improvements in some of the other inflammatory markers and oxidative stress things that we've talked about and you've talked about in your presentation. So I think, there's evidence that it can be done in these patient populations safely, and that it can be beneficial in many different ways, and in some ways, maybe the exact same way that doctors treat some of these disorders.
Exactly. I think we go at it like that. And by the way, we might, it looks like we can reduce blood pressure, or, if the German Diabetes Center comes out, it looks like we can reduce insulin levels, or it looks like we can reduce oxidative stress and improve these people's endothelium. And, extra, they get some muscle from it, along with it. It's like a win-win, and, everything else they can do while they're seeing us. And so we just need more and more of these funded big trials to help fight our fight. And I think that's where Annie Bain's Parkinson's study I talk about at the very end that we worked with her, and she's awesome, was so perfect because it took all these kind of concepts and it said, okay, now let's look at diseased individuals who had terrible vasculature. their endothelium was just a hot mess. They got purple hands. They lifting heavy looks like it helps functionally for Parkinson's people, but you know what? It doesn't look like it does great things for their vasculature. It makes it kind of worse. And she showed that. And when they lifted heavy, it got worse. If they did 1 month of BFR, it significantly improved their endothelium. They had an angiogenic effect. They got stronger as well. So it was just like boom, 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 1-2 punch. The conclusion is like,
apparently the subjects were coming back saying, when can I start doing this again, kind of thing.
Yeah, they're like, when's the next trial?
Or like if you're getting buy-in from your patient, But
and one of her conclusions was, this might be, these people need to come in once a month, or for a month a year, just to get some endothelial work from us, which I don't think anyone other than maybe your folks, Larry, have thought about. Like, they need to come see us to get their endothelium work on, because that's a bigger problem. I mean, the more I've got into it, it's like, holy shit. Oh, damn it, Kyle.
There we go. I got to put the E on there. Here we go.
The endothelium is the problem in these people.
For sure.
Yeah. No, I think, and that study Johnny's talking about, we're gonna bring Annie on the podcast at some point, and Larry, we might just get you to come on that one too. That would be a fun conversation, because she's certainly very passionate and has done a very cool study through.
And Larry knows Annie now. We
did a call. She's a good person.
Yeah, that's awesome, and a TV star now too.
Yeah,
from what I understand, really? They're going to be on the the gym that she and her husband own are on. What's the new cult in Waco? The Chip and Joanna Gaines.
Yeah, Magnolia.
the Magnolia cult down in Waco.
Yeah,
they have a new
that's great
TV channel, and so they're featuring Annie's gym.
That's
I was like, Annie, don't give up on research. You're too good.
Yeah.
Don't become a reality show star.
No, exactly. And she submitted to CSM, I believe, I think in the neuro section. I think she submitted to do like a platform talk or something to that. So she might actually be presenting this year. I haven't heard anything, but I can check in with them, because one of her colleagues out there in Abilene, Jill Jumper, is a good friend of mine. She was my classmate in PT school at Hardin-Simmons University. So some very, very cool study.
Reach out to her, because I'll bring her in on my platform.
Well, I was thinking that. that too. We'll find that out and
cool.
And really work
if we have CSM.
Yeah, right.
Yeah, knock on wood, fingers crossed, all of that. Well, guys, I think this was an awesome talk. I think our listeners will really enjoy it. And you guys, if you did listen and you haven't seen Larry's Pacer Talk and Johnny's Pacer Talk, please go over to the YouTube channel for the cardiovascular and pulmonary section of the APTA, or you can go through the Learning Center on the APTA's website and you can get free CEUs by watching those talks. And then I'm assuming you have to answer quizzes and things like that.
Larry just submitted our questions today. So good.
Nice.
Yeah. And we'll
put all the answers C. Did you make all the answers C, Larry?
It's all B.
It's all B. Okay, so now you know, if you listen to the end, you know how to pass the test. It's all B. We get some angry viewers or listeners back, and they're like, "That wasn't right."
But I'm proud of it. I'm proud of Larry's, and I'm proud of Larry's work he did with me. So I really hope people. It's a lot of deep stuff, but I think people should really take these in. It's interesting stuff.
And you presented it beautifully. I mean, the progression, the content, and just the way everything developed throughout was great. Almost like a movie.
Well, that was Kyle's graphics.
There you go.
This is my animation hole that I went down.
We'll put links to all of them in our show notes here, so people can go to it. Okay.
Cool. We will do that. Well, Larry, Johnny, thanks for coming on the Owens Recovery Science Podcast with Kyle Kimbrell. I really appreciate y'all participating in this episode. And you guys stay safe.
Thanks, Kyle.
Cool. Thanks, Kyle. See you later, Larry.
See you, Johnny. Take care, you guys.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.